the patient who is presenting with this stage 1 of synovitis will be having the attitude of the limb in flexion, abduction and external rotation. This is a mistake over here. It is not adduction, it is abduction. Flexion, abduction and external rotation. Alright, so flexion, abduction and external rotation will be happening in this case. Now what about this limb length? Because you know, whenever the patient comes to you, you will examine the patient. You will examine the patient by placing him on couch. You will ask him to lie supine on couch, and then you will have a just apparent look on the length of the limb. You will look for the limb length discrepancy and how is it helpful in making the diagnosis, or how is it helpful in grading the stage of the tuberculosis. Just try to understand. Now here the patient is having an abduction deformity. Imagine the patient is having normal hip. So in order to have a bipedal stance, that means when both the feet are touching the ground, the limb are going to be parallelly kept. Alright, this is normal. But imagine if the patient is having an abduction deformity. For example, this is a patient who is now having an abduction deformity of the affected hip, where the hip is kept in slight amount of abduction. This is just a diagrammatic representation, so abduction is over exaggerated in order to explain it. Now the patient is having an abduction deformity. Would he be able to stand with both the feet parallel on the ground? Obviously not. But in order to have this bipedal stance where both the feet are meant to be kept on the ground, there has to be some adjustment at the level of pelvis. So what those adjustments are going to be, that the pelvis on the affected side has to tilt down. So what happens is, when the patient who is having an abduction deformity, there will be a down tilting of the affected side pelvis in order to have the bipedal stance. Then only the patient can manage to put the foot on the ground parallel to the other one, parallel to the normal one. Now, imagine such a patient who is lying supine on couch. When you are examining the patient is lying supine on couch, then the length of the affected limb will appear longer compared to the normal limb. It will appear longer compared to the normal. Now, what are the reasons for that? Because of the compensatory down tilting of the pelvis on the affected side. Because the pelvis is relatively tilted down, the length of the affected limb will appear longer compared to the normal. But when you square the pelvis back to normal, alright, there will be appearance of the abduction deformity. So this is the reason why this stage is known as a stage of apparent lengthening. It is not the true lengthening which is happening over here. It is apparent lengthening, that the limb length seems to be increased compared to normal. Hopefully everything is clear related in stage 1. So stage 1, what will happen? This is the stage of synovitis, and what all is happening in this stage, the limb or the thigh or the hip joint would be kept in flexion, abduction, external rotation, and the length of the limb will be appearing longer compared to the normal, although this is not the true lengthening, because when you measure the size of the limb, both of them are equal, or both of them are found to be of the same length. It is only because of the compensatory down tilting of the pelvis on the affected side. So that is point number 1, stage of synovitis. Next, over a period of time, what will happen? This inflammatory stage will be converting into an arthritic stage. Now, in arthritic stage, what will happen? That the head of the femur and the acetabular joint surfaces will be eroded. So there will be erosion of the head of the femur and there will be erosion of the acetabulum. As a result of which, both these two surfaces, nerve endings, will be exposed to each other. You know, the nerve ending of the head of the femur will be exposed to the nerve endings of the acetabulum, and similarly the nerve endings of the acetabulum will be exposed to the exposed head of the femur. So when there is a frictional movement in between the two, the condition is extremely painful. So again, the patient has to acquire the attitude involuntarily to limit the pain of this condition, pain due to this condition. Now, how that attitude will be helpful in limiting the pain is that if there is a pain because of movement, then you have to block the movement. In order to achieve or in order to decrease the pain because of this condition, there has to be a movement block. Now, this movement block is achieved by spasm of all the muscles. Spasm of all the muscles, that means contraction of all the muscles which are present around the hip joint. Now, hip joint, there are flexors, there are extensors, there are abductor, adductor, there are external and internal rotators. all these 6 set of muscles, they contract to their maximum forces. And because of this contraction with their maximum force, there will be a block in the movement of the hip joint. And when there will be no movement, there will be no frictional rubbing, because of no frictional rubbing, the patient will be having lesser pain. But there is a problem. When both flexors and extensors, they are contracting with their maximum force, and because the flexors are having greater strength compared to extensors, the limb will move into flexion. Similarly, adductors and abductors, both of them are contracting with their maximum force, but because adductors are stronger, the limb will move into adduction. Similarly, internal rotator and external rotator, both of them are contracting with their maximum force, but because internal rotation or internal rotators are stronger, so it will pull the limb into internal rotation or medial rotation. So the patient will acquire the attitude of, in case of a stage of early arthritis, there will be a flexion, adduction and internal rotation. All of you know what is a wrist fight. In a wrist fight, what happens? Both the opponents are using their maximum force, but the one who is having greater power will win. Similarly, flexor and extensor, both of them are contracting with their maximum forces, but because flexors are stronger, so it will move the limb into flexion. And the same thing happens in case of adductors as well as internal rotators also. So hopefully the attitude of the limb is clear to you, or the reasons behind this attitude is clear to you. Next, now in this scenario, what is happening? The things are getting relatively changed, because in this scenario, the patient is not having abduction deformity. Here the patient is having adduction deformity, and in order to have the bipedal stance, all right, in order to have both these feet on the ground parallel to each other, there has to be up tilting of the pelvis on the affected side. Because of this adduction deformity, there has to be a compensatory up tilting of the pelvis on the affected side. All right. And when you make such a patient lie supine on couch, then the length of the affected limb will appear smaller compared to the normal because of the up tilting, compensatory up tilting of the pelvis. And that is the reason why this stage is known as the stage of apparent shortening. All right. It is not the true shortening, because it is the earliest arthritic stage. It is not the advanced arthritic stage where there will be a destruction of the head. Hopefully everything is clear related to this stage 2 also. And you can also make out that there is a difference in between stage 1 and stage 2 of the same condition. That means tuberculosis of the hip joint. Next is advanced arthritis. Now over a period of time, what will happen? That head of the femur will be eaten away by the organism. If this is the normal head of the femur, which had the diameter of, for example, 5 centimeters. Now, because of this head of the femur eaten away by the organisms, now the head of the femur diameter is restricted or limited to, for example, 3 centimeters. All right. It is limited to 3 centimeters only. And rest of the joint is also destructed. Rest of the some amount of the acetabulum, because of the osteopenia, is also eaten away by the organism. So what will happen? There will be a true shortening. The attitude will remain the same, although with increased angular deviations or increased angular severity. For example, the patient had a flexion, adduction and internal rotation deformity in early arthritis. What will happen in late arthritis? There will be flexion, but of increased angular deformity. There will be adduction, but of increased angular severity. There will be internal rotation, but with increased angular severity. For example, if previously it was 10 degrees of flexion, now it will be progressed to 20 degrees of flexion. If previously it was 5 degrees of adduction, now it is progressed to 15 degree or 10 degree of adduction. So there will be increased severity, but the attitude will remain the same. That means flexion, adduction and internal rotation. And this time, because the hip joint components of the hip joints are eaten away by the organism, there will be a true length discrepancy. And this time the patient will be presenting to you with the true shortening. For example, if 3 centimeter, this is just an example, because it is not like only the head of the femur will be eaten away. It will be because of the reduction in the joint space also. It will be because of the head destruction also, acetabulum destruction also. But this is just for the example that previously, for example, it was 5 centimeters and now it is just 3 centimeter of the head of the femur left. So there will be a true shortening of 2 centimeters. All right. So this is how the advanced arthritis is different from the early arthritic stage. Hopefully everything is clear related to this particular topic. And finally, what will happen when the head of the femur will remain too small? that it will be failed to kept inside the acetabulum, it will be dislocated, and finally it will be culminating into a stage of dislocation. That is the end stage of tuberculosis of the hip joint. That means dislocation of the hip joint. All right, because the acetabulum, it fails to keep this small head of the femur within its confines, so it gets easily dislocated. So these are the stages of tuberculosis of the hip joint. So many questions could be formulated or created out of this particular table itself. They can give you an individual long question based on this table itself. All right. So this is something which you have to learn it by practicing it again and again. In a same condition, tuberculosis of the hip, the clinical presentation could be variable. Means there is a varied presentations as far as clinical features are concerned. Next are the X-rays. It is not very difficult to have a distinguishing features on the X-rays, like, you know, when too much of the infection is happening at the hip joint with the components, then there will be reduction in the bone density, and that reduction in the bone density is osteopenia. All right. So periarticular means adjacent to the joint, whatever the bones are there, there will be decrease in the density of the bony surfaces. So this is periarticular osteopenia. Next is reduction in the joint space. In any of the tubercular inflammatory condition, it will happen over a period of time, or it is considered to be the earlier X-ray findings. Like in case of tuberculosis of spine, we have seen that there was a reduction in the disc space. In case of tuberculosis of the hip joint, what will happen? There will be a reduction in the joint space. All right. Wandering acetabulum. You know, although this might happen in many other conditions also, wherever there will be a destruction of the head in relation to the acetabulum. But this term wandering acetabulum was coined for tuberculosis of the hip joint. And what is happening in this wandering acetabulum? That is, when the head of the femur becomes too small, then the congruency in between the two is not matched. So the two bony surfaces, there will be no matching as far as the articular congruency is concerned. So it seems like acetabulum is looking for head of the femur. Acetabulum is looking for its periarticular confines. All right. Wandering, it is locating for the head of the femur. So that is wandering acetabulum. And finally, pestle in motor appearance, because the head of the femur becomes too small, it appears like a pestle in the acetabulum, that is motor. All of you know that pestle in motor is the Oakley. All right. So head of the femur, because it appears too small, it will be appearing like a pestle which is kept in the motor, that is acetabulum. Now, as far as the X-rays of tuberculosis of the hip joint is concerned, now what all we have discussed, it could be easily correlated in the image which is provided over here. Now, you know, this is the affected side, this is the abnormal side, and this is the normal side. Now, what is important for you to identify in this case in particular is the joint space. You know, this is the acetabulum and this is the head of the femur, and there is a clear-cut visibility of the joint space over here. But here the joint space is markedly reduced. Second is, if you look at the density of the head of the femur and the adjacent structure, then the density is relatively more over here and the density is relatively less on the affected side. So, although these X-ray findings are not clear-cut demarcating kind of the X-ray findings, that means on the X-ray itself, you cannot diagnose the condition just by looking at the X-ray. But every time you get the X-ray of a tuberculosis of the hip joint, then it will be coupled, or it has to be coupled with a long question on the basis of which you will make the diagnosis by the combination. All right. So this is how the X-ray of tuberculosis of spine are important. As far as X-ray related to TB's hip joint is concerned, what you have to remember is that reduction in the joint space is the earlier X-ray finding. It is not the late X-ray finding. And now comes the management, the treatment protocol. Now, every time the patient comes to you with the tuberculosis of the hip joint, the first thing that you have to start with the ATT, anti-tubercular regimen, then put the patient on or apply a traction, particularly a skeletal traction is required. All right. A skeletal traction is required in order to pull the adjoining joint surfaces, the fusing joint surfaces, the reduced joint surfaces, all right, and to relieve the periarticular muscular spasm. All right. So what is the role of this skeletal traction? It is to relieve the spasm and to prevent the joint reduction. All right. So joint reduction, that means joint fusion is prevented, as well as the muscle spasm is relieved when you apply a skeletal traction on that affected limb. And then finally, the surgical methods. You know,